Hi guys, welcome back. We shall now talk about FUO, that is fever of unknown origin, also called as pyrexia of unknown origin. To understand this topic, we will first talk regarding diurnal variation of temperature in our body. You can see that the maximum temperature is usually seen in the evening hours, whereas the least temperature is seen in the early morning hours, usually around about 4 a.m. in the morning. To keep the uniformity in the discussion, I will try to use Fahrenheit as a unit most of the time. The normal diurnal variation of temperature in our body is always less than 0.9 degree Fahrenheit. The reason why the temperature is higher in the later part of the day is explained by one, basal metabolic rate, which is higher at the later part. Second is the physical activity or the muscular activity, which ensures a relatively higher body temperature in the late evening hours. Why this is important for you to know is because when they will ask you the definition of fever, then do remember the fact that the AM, that is the morning cutoff for fever, and the evening cutoff for fever is not the same. According to Harrison, he says that morning temperature of more than 98.9 degree Fahrenheit and evening temperature of more than 99.9 degree Fahrenheit should be taken as fever. I repeat my statement once again. Why he has given two definitions is because of the fact that our temperature is not constant and it keeps on fluctuating. We all have a circadian rhythm, or we have a diurnal variation of our body temperature. Now, more than how much will be troublesome, or more than how much will contribute to hyperpyrexia, then the cutoff for hyperpyrexia is more than 107 degree Fahrenheit. This can be associated with heat stroke. Most of the time in a hot environment like the month of May and June in our country, imagine a construction worker who is working out or sweating out under the sun and is not even getting routine water to drink. Very soon the sweating in the body will stop, because the sweating is a mechanism of cooling of the body, but because of loss of water from the body on account of excessive sweating in this person, a stage would come when the sweating will stop. Once the sweating will stop, the cooling mechanism of the body is not working, so the body temperature will start increasing to a level that it might even cause a development of heat stroke in this individual. The opposite of this is hypothermia, which is defined as body temperature less than 95 degree Fahrenheit. However, in most of the MCQs that have been asked in the previous years, for hypothermia, he has asked the question with respect to Celsius. So I would like to here use the value of Celsius, that is 35 degrees Celsius less than 95 degree Fahrenheit alternatively. He has also asked the classification of hypothermia, that is mild is 32 to 35, moderate is 28 to 32, and less than 28 would be classified as severe hypothermia. Well, it is unlikely that we civilian doctors will see severe hypothermia, but doctors who are posted in the army, doctors who are handling mostly our soldiers who are battling in the Siachen Glacier at high altitude in Jammu and Kashmir, Leh and Ladakh, they are the ones who are prone to development of hypothermia, and severe hypothermia also has a ECG finding which has been asked in the exam, and therefore I would like to remind you that is J waves or Osborne waves is one of the ECG findings of hypothermia. They've also asked in the previous years that what is the ideal site for checking the core temperature. You see, we can use rectal thermometer also, but the ideal site where we should place the thermometer for measuring the core temperature in the body is the pulmonary artery, because that will give you an exact representation of the temperature of the blood. But because it is highly invasive, therefore in Harrison it is also mentioned that the preferred site for checking the core temperature in the body happens to be the lower esophagus. We can use thermometer in the axilla or in the oral cavity, or we can use it in the rectum, or for that matter of fact in the lower esophagus and even in the pulmonary artery. But do remember my data's ideal site and preferred site being respectively the pulmonary artery and the lower esophagus. Once you're aware of these baseline cutoffs, then I want to say that once a person will start having fever, then the pulse rate will jump up. Clinical studies have shown that if the temperature of an individual is increasing, in those circumstances, the pulse rate of the person will also tend to increase. Usually, the temperature increases more than 100 degree Fahrenheit. For every 1 degree Fahrenheit rise after 100 degrees, there is an increase in the pulse rate by 10 beats per minute. To record the temperature, as I mentioned before you, there are various devices that can be used. So one I have shown a commercially available rectal thermometer. Remember the fact that the value of the rectal temperature will be approximately 0.7 degree Fahrenheit higher than what is recorded in the oral readings. I have tried to use a consensus of Fahrenheit wherever possible, only in hypothermia because it is asked in Celsius, so I have explained rather like that. In pediatric age group, it is relatively easy to get the rectal side, but in adults, considering that the person's weight will be relatively more and it will not also be very convenient, therefore, though I have shown a rectal thermometer even which is available for use in adults, you can understand that the discomfort associated with that will be substantial. That is why I said lower esophagus is the one that is preferred to record the temperature. Rectal thermometer is more accurate than oral, but otherwise on a comparison base, lower esophagus would be superior as compared to all others. I did not talk about tympanic thermometer here because TM temperature, tympanic operates on infrared. And let me say, in a case of a soldier who has been airlifted from Siachen Glacier, if there is ice or water in the ear, then that could interfere with the conduction of heat, and therefore the temperatures may not be very, very accurate. I repeat my statement: for every 1 degree Fahrenheit rise of temperature above 100 degree Fahrenheit, the pulse rate of the patient should increase or jump up by at least 10 per minute. However, in certain conditions, we will always find that the temperature will start increasing, but the pulse rate may not increase correspondingly. What I'm talking about is a hot favorite of our examiners and is called as Faget sign, or is called as relative bradycardia. There are multiple causes of relative bradycardia that I will explain to you now. But first and foremost, just get the basics right. Relative bradycardia is more common with gram-negative organisms and infections of bacteria that are transmitted by ticks. That would help you simplify the data. The mnemonic that I would like you to remember for Faget's disease is TBM CLR. So we will just fill up the data for TBM CLR so that it becomes a permanent memory for you. The first one, for relative bradycardia, I usually don't find anybody making a mistake because everybody knows that relative bradycardia is a feature with typhoid. The extra information that I want you to remember is tularemia. Now, tularemia usually comes from ticks, and tick which was living on the body of a rabbit. You see, I can put it like this: this guy is a hunter by profession. He shot a rabbit or he shot a deer, and when he was handling the meat or he was skinning the carcass of the rabbit or the deer, the tick on the body of the deer or the rabbit bit the hand of this hunter, and therefore he developed enlargement of axillary lymphadenopathy and ulcer on the hand. You would have read about tularemia in microbiology as ulceroglandular fever. Tularemia can be one of the rare causes for development of fever of unknown origin, and this would be obviously a disease that would be found in more people who are, let me say, going for hunting by either requirement for food or by for hobby. So whenever we are talking about fever of unknown origin and we are taking history of a person of fever of unknown origin, we do take into consideration the hobby of an individual and try to evaluate the history of contact with animals. The next need to be remembered is scrub typhus, which is transmitted by the baby mites. The baby mites are called as Chiggers, Chiggrs. So for the mnemonic, by the name of TBM CLR, the T data has been explained to you. We come to the B component here. The disease that I'm describing here is called as undulant fever, or is also called as brucellosis. This is usually transmitted by consumption of raw milk or unpasteurized milk. The next B is an organism which is a differential diagnosis of malaria, Babesia microti. Babesia microti is anyway a hot favorite of our examiners because in the peripheral smear of Babesia microti, there can be a very specific finding which is called as Maltese cross appearance. For Maltese cross appearance, there are multiple other MCQs also which are to be remembered and I have discussed in other series, and I'll repeat them here also. But at the moment, remember, peripheral smear finding showing Maltese cross appearance inside the RBC is a feature with Babesia, and these people would be having a relative bradycardia. For the M component, I want you to remember this infection, which is a cause of atypical pneumonia by the name of Mycoplasma pneumoniae. This is a cell wall deficient organism. Even malaria has relative bradycardia. So there are two M's here, malaria and Mycoplasma pneumonia. Coming to the C component, it is Coxiella burnetii. The alternative name for Coxiella burnetii is Q fever. I was very curious when I was your age to find out why they call it Q fever. So I asked my consultants, they rather scolded me. But I do get queries, from young chaps like you. I can't scold you. So things have changed. We never had the guts to ask our seniors. Now I straight away get messages. What do you mean by this? So Q fever basically means query fever. Coxiella burnetii or Q fever is mainly transmitted by contact with animals. That could be like keeping cows at home or buffaloes at home. You see, when you talk to American person and say that you are having cows in the house, it's very surprising. But if you go to rural India, we do have cases where there would be a small house, a hut, with maybe two cows and a buffalo sharing the same space. Why that is important for you to know is that rheumatic fever is common in India. Now, this rheumatic fever child, if he's in contact with animals, he could get this Coxiella burnetii infection, and this could infect his heart valves, and you could have infective endocarditis. And as you would have studied from your background knowledge, you are aware that subacute bacterial endocarditis could be a presentation with respect to fever of unknown origin. So, contact with animals anyway has to be illicit. The next disease, however, is relatively less commonly seen now, Corynebacterium diphtheria, thanks to the vaccination component. But there are two C's which are to be remembered, Coxiella and Corynebacterium diphtheriae, which are reasons for development of relative bradycardia. Alphabet L would stand for Legionella pneumophila. The speciality of this infection is that it can be transmitted by water droplets. Please appreciate, normally water droplets are for diarrhea, right? Water, when we consider it's like for diarrhea, I'm saying inhalation of water droplets can contribute to Legionella pneumophila infection, and then would be leptospira. So there are two L's here which are to be remembered. Alphabet R would stand for Rickettsia. This is a list of bacterial infections which are responsible for development of relative bradycardia, and I will reiterate the statement that mostly this list encompasses bacteria which are gram-negative or which are tick-borne infections. After this, we will talk about viruses which are responsible for relative bradycardia. Two important names to be remembered by you for questions are, and you would have seen also in your words, are one is dengue fever, and the second infection thankfully is not found in India, that is yellow fever. Once you remember the viral infections responsible for relative bradycardia, then we come to relatively less causes. One could be drug fever. Well, what are the drugs that could contribute to it? There's a whole list, but important ones that I wanted to remember right now, it could be one, allopurinol, which is very commonly used in postmenopausal women with gout. Please appreciate that in lot of postmenopausal women, there could be hypertension. For hypertension, we are giving thiazides, and thiazides can cause gout. So look at the relation. You see postmenopausal lady, she's having hypertension. Most women are protected against hypertension by their hormonal profile. Postmenopausally, the hormonal profile changes, estrogen values decrease, so they become hypertensive. In old age, you might write thiazide diuretics, and if you're giving thiazide diuretics, side effect is gout, and one of the medicines for gout, allopurinol, can contribute to development of fever, which could be responsible for fever of unknown origin. Another important drug to be remembered is beta blockers, and then is sulfur drugs, which you routinely prescribe in a PHC, and government supplies sulfur drugs, intake of which can contribute to fever, but it would be associated with not a tachycardia, but rather a heart rate to be on the lower side, corresponding to the fever grade in the person. The next term is factitious fever, which would be seen in mainly healthcare workers. This is a healthcare worker, it's mostly a she, it's a female, and she, for some secondary gain, she is injecting into herself distilled water or infected distilled water. So injection of infected distilled water into the body will contribute to fever. So this will mostly be a person who will be having access to healthcare services, who knows how to give an IV injection and is self-injecting with distilled water. Surprising data, but that is how it is. Then I wanted to remember CNS lesions can contribute to central fever. Most of the time, you would have read, and I would definitely like to invest about 30 seconds into it. You would have always read, no, pontine hemorrhage is responsible for central fever in a person, and it could be associated with relative bradycardia. So what is great about pontine hemorrhage? What is so great about pontine hemorrhage that it causes a development of fever? After all, hypothalamus is much more superiorly placed as compared to pons. However, when you will read regarding the control of the body temperature, you will read regarding an anatomical structure which is called as the parabrachial nucleus. This parabrachial nucleus is present at the junction of the midbrain and the pons. The location of parabrachial nucleus is at the junction of the midbrain and the pons, and it is in direct connection with the hypothalamus, and it helps you to regulate body temperature. If there is a pontine hemorrhage, the expanding hematoma will press on this parabrachial nucleus, which results in a resetting of the hypothalamus, and resetting a hypothalamus at a elevated temperature will contribute to what you call as central fever. So pontine hemorrhage does not cause direct damage to hypothalamus, but helps in or contributes to central fever by affecting the relay into the anterior hypothalamus, and the relay into the hypothalamus is affected, so therefore the hypothalamus sets the body temperature at a higher level, which contributes to fever. The next reason why you could be having relative bradycardia is lymphomas, mostly non-Hodgkin's lymphomas. We will read about Bell-Epstein fever in a while, that is seen with Hodgkin's lymphoma, but incidence-wise, non-Hodgkin's lymphoma are more common than Hodgkin's lymphoma. So this is a comprehensive list of reasons why do you have a development of Figert sign, why do you have a development of relative bradycardia in the person. Let's quickly recap this. The mnemonic is TBMCLR. Alphabet T would stand for typhoid, tularemia, and then typhus, that is scrub typhus, which is transmitted by Shiggers, Brucella, and Babesia, then mycoplasma and malaria. So TBM, that's a must know for you, because most of the time they have given these in the question, and they said all of the following contribute to relative bradycardia except, so that's why you need to use orientation to remember it. C would be two of them, that is Coxella burnetii and Corynebacterium diphtheria, though Corynebacterium diphtheria nowadays is lesser thanks to the vaccination part. Then is easier Legionella, Leptospira, and Rickettsia. So just remember this fact: gram-negative bacteria and tick-borne infections are relatively common causes of relative bradycardia, and mostly the question will revolve around these bacterial causes only, because viral causes are easy to remember, only two of them, dengue and yellow fever, and then drug fever, etc. people are still able to rule out. Once you get the data right for relative bradycardia, we will now focus upon the subsequent part, that is the patterns of fever in a person, because when you study fever of unknown origin, you should know the patterns of fever. Only then you can evaluate like how long the fever is present, how long the person is afebrile, is he getting a fever once again, what do you mean by the word relapsing fever. So we will try to discuss regarding the meanings of these terms so that we can take a better history of our patient. To take a better history in your patient, it is therefore important that you study regarding the various patterns of fever that can be elicited in your patients. In the first image on the left hand side, you can see that the person is having a continuous fever, which will also be called as sustained fever. One of the highlights of continuous fever is it will never ever touch the baseline, and the diurnal fluctuation of this fever or the variation in this fever will be less than 1 degree Fahrenheit. In contrast, if you look at the image below this, you will notice the fact that the fever is again now touching the baseline, but the fluctuation in the value of temperature is more than 1 degree Fahrenheit in a person. What we've learned is if the fever does not touch the baseline, there can be two possibilities: continuous fever or remittent fever, and the difference in the two is in the magnitude of fluctuation. On the other hand, if the fever touches the baseline, then we call it intermittent fever. If you just go by the English word intermittent, no, so in between it comes back to normal, then again spikes up. Intermittent fever can have a variation usually in excess of 1 degree Fahrenheit. The main feature is touches the baseline. In contrast, if you look at the next image, we are showing a relapsing fever where like the person was having fever for 3 days, then he's not having fever for 3 days, and the fever will again start coming up. You will usually read about relapsing fever in literature of Borrelia recurrentis, and can also be seen with rat bite fever. Whereas intermittent fever is what is usually noticed in persons with malaria, where the person will have sweating, then the temperature might come back to normal, but it will go back and spike again. You will notice the fact that when it comes to malaria, you will read about terms like Quotidian fever, or you will read regarding tertian fever, or let me say the term Qualton fever. Quotidian fever basically means that the fever will be occurring at least once every day and the fever will be touching normal. Quotidian fever is an example of intermittent fever. I repeat my statement. I'll just go back to my previous slide so that I can show you this once again. When I said intermittent fever, the fever was coming back to normal. You can see that this fever is touching back or is touching the baseline, and the fever is occurring every 24 hours. So medical conditions where this is definitely a possibility is one with falciparum. The highlight of falciparum malaria is that it can infect all the types of RBCs, immature RBCs, mature RBCs, reticulocytes can be infected. So because the multiple generations of RBCs are affected and each of them would die at a particular time after the infection phase, so therefore fever can occur every 24 hours. So falciparum and Plasmodium knowlesi are associated with Quotidian fever. However, in some MCQs, you will read about a term by the name of double Quotidian fever. In double Quotidian fever, the fever will be spiking twice per day. That is, it will touch the baseline, again spike in a single day. Unlike in Quotidian fever, where the fever is gonna come down at the end of the first day, the end of the second day, here you could be having 2 spikes of fever in a single day itself. So it's like one day there are 2 spikes of fever on a single day in a person. Condition where you have a double Quotidian fever is Adult onset Still's disease. Adult onset Still's disease would mean juvenile rheumatoid arthritis. Though this is not a hard and a fast rule, and nowadays because of easy availability of paracetamol and antipyretics, these patterns of fever may not be elicited. But because they're given historically in the textbooks, therefore, at the moment, I would like you to definitely remember them. We now look at the second image where you can see that the fever is occurring after every 48 hours. That is, the fever is occurring every 3 days. So because it is occurring every 3 days, we are going to call it tertian fever. The highlight of tertian fever is that the gaps between the spikes of two fevers are separated by 48 hours. Tertian fever is a common presentation that is seen with Plasmodium vivax and ovale. In contrast, when it comes to Plasmodium malariae, you would have read even in microbiology that malaria will be having spikes of fever that would be separated by every 72 hours. So therefore the fever spike might occur every 4th day. So therefore the word is quartan because the spike will occur on the 4th day that is separated by every 72 hours. So do remember my terminologies because quartan sometimes they will say fever coming every 4th day, but in most of the medicine textbooks they have described not the word 4 but they are saying 2 episodes are separated by. So I repeat my statement. In the first image, every episode is separated by 24 hours, so Cutodian fever. Every episode is separated by 48 hours, tertian fever, vivax ovale, and quartan fever is a feature that is seen with malaria. Let's look at another image based on the explanation that I provided, where you can see that there is definitely fever, but it is showing a declining trend. If this is asked as an image-based question to you, I usually find when I ask this in a routine class, a lot of guys casually answer stepladder pattern of fever. You see stepladder pattern of fever, I agree, but in stepladder pattern of fever, fever should be rising, here it is decreasing. So this particular person of typhoid has been given antibiotics and now he's in a defervescence phase where the fever is basically coming down. So here we will say that the fever is resolving in a person. The fever is resolving in a person. There is a fever resolution with lysis. The word lysis basically implies a gradual stepladder pattern of decrease of temperature in a person, especially after intake of antibiotics. Most of the time when you start giving ciprofloxacin in a routine case of typhoid, the lysis might take maybe 5 days, maybe 6 days, but with ceftriaxone you have a faster lysis, especially in cases of typhoid. Stepladder pattern of typhoid is very rarely seen, so I had to look up at image from a textbook which I had to which is also available on Google, and this image is basically showing the stepladder pattern of fever that is occurring in a person, and when you're giving antibiotics to the person, the fever is also coming down in a stepladder pattern, so that is called as fever lysis. The stepladder pattern of fever is seen with typhoid, and you also remember from today's discussion that typhoid will be having relative bradycardia. Now, if you look at the next image, you will notice that the fever is precipitously suddenly falling. In this case, the term that we will use will be that the fever is settling, the fever resolution is occurring, but we will not say fever resolution by lysis, we will say fever resolution by crisis. A very peculiar term, fever resolution or fever settles by crisis. This is usually a feature that can be seen in acute tonsillitis. If you ever had a bacterial tonsillitis, you can understand what I'm saying. The fever would be very high grade, and then suddenly once the antibiotics are given like Augmentin, etc., the fever would suddenly come down. Another case would be resolving phases of pneumonia. There's a sudden crashing of the fever. So unlike in typhoid where it was like a stepladder pattern of fever coming down, you can see the fever is suddenly falling down. Then are a couple of very interesting terms which have been asked in the exam for special kinds of fever. So one is Katayama fever. This is usually associated with schistosomiasis. Another very surprising term that you will come across, and I have already set an insight into, is Q fever. Q here means query fever. The organism for this is Coxiella burnetii, and this organism is nasty enough to cause infection of the heart valve, so it can cause endocarditis and is difficult to diagnose. Then is a term by the name of parrot fever, which you can answer better. I usually get answers here. Parrot fever would be psittacosis, that would be Chlamydia psittaci. So once you get an insight into the patterns of fever that are described before you, it basically helps us in asking the patient better. I mean, you can ask that, okay, after how many hours the fever spike is coming. So your questioning becomes better if you have studied these patterns of fever in a person. Based on the explanation that I provided to you, we will now be studying regarding 4 points which are essential for diagnosis of pyrexia of unknown origin. So let's just enumerate those 4 points one by one. The first and the foremost thing that should be satisfied is obviously demonstration of fever, ideally by a digital thermometer, and the magnitude should be more than 101 degree Fahrenheit. If you demonstrate this fever to be present at the cutoff that I mentioned at least more than 2 times, and the duration is more than 3 weeks, your patient will be very frustrated by this time because he had made multiple visits to your hospital, got multiple workups done, but at the moment the diagnosis has not been made. So you need to tell the patient to be patient so that you can work out the entire algorithm which is provided for finding out the root cause of the fever of this person. Lots of time because patients lack patience. Therefore, I repeat my statement, patients lack patience. We doctors are patient, right? Patients lack patience. They might change the doctor due to which the diagnosis may never be made, and these patients might keep on shuttling and shuffling from one doctor to another without any conclusive evidence of the basic cause of diagnosis. The third diagnostic criteria is that there should be absence of immunocompromised state in a patient. That's very obvious because there's a different algorithm for immunocompromised states like AIDS. What I say in the fourth point is the most important part of the entire discussion of PUO because the entire discussion is resting on the fulcrum of point number 4. Here he says that the doctor is not able to confirm the diagnosis. There is an uncertain diagnosis in spite of a thorough history taking. You have spent sufficient time with the patient asking him regarding occupational history, possibility of contact with animals, whether it could be due to hobby or maybe because of profession. You have asked the person about his travel history, whether he's gone to an area where some kind of infection is endemic, but there is no conclusive evidence provided to you. You have done a thorough physical examination. I will discuss with you what are the body systems that are must to be checked in thorough physical examination. But the doctor has taken a proper history, done a proper physical examination, and has done obligatory investigations. And that is what is the most important point of the discussion and is usually the one that is quizzed. The obligatory investigations which are to be done in the patient, the first one will be to identify whether he could be having any hematological illness, because if a person is having, let me say, a lymphoreticular malignancy, then definitely there will be derangements in the TLC, DLC or the platelet count of the patient. Most of the time in your practice you will write the word complete blood counts with erythrocyte sedimentation rate so that you can come to the possibility that he might be having a lymphoreticular malignancy. Then the next test you will write will be one for acute, indicating that there is acute inflammation, because if C-reactive protein is positive, or there is a elevated LDH in a patient, or there is a elevated ferritin in a patient, then all of these are acute phase reactants which indicate inflammatory state in a person. It could indicate not only infection, but it could also indicate non-infectious inflammatory causes which are important in Western population. You see, in India, the leading cause is obviously infection. Most of the time it is extrapulmonary TB, but abroad it is mostly non-infectious inflammatory causes which are responsible. Then we will check the patient's kidney, because kidney could be suffering from the impact of this infection. So KFT with electrolytes will be done. Next, we will evaluate the liver of the patient. That is, a liver function test will be done. In liver function test, we will mainly be focusing on the liver enzymes like SGOT, SGPT and serum alkaline phosphatase, because a lot of these infections can damage the liver, and therefore if the liver enzymes are elevated, you can pick up that okay, there must be infective cause present or even an autoimmune cause which could contribute to derangement of these liver enzymes in a person. We will simultaneously check for the total serum protein, in which we will also check for albumin globulin ratio. You see, if the liver is damaged, then the albumin will become lesser. But if suppose he is having a connective tissue disorder, then globulin will be elevated. So albumin globulin ratio derangement will also give you an idea regarding the fact that there is something wrong with this chap, because I said one, globulin elevation definitely tells you either there is an infection or there is an inflammatory state occurring in the patient. The next investigation to be performed in the patient is serum electrophoresis. The reason why we're doing a serum electrophoresis is to pick up monoclonal gammopathies, and I can put it in old patients, especially geriatric age patients, multiple myeloma, where if you're having a presence of M spike, that is one of the screening tests for multiple myeloma. All of you are aware that in multiple myeloma, the antibody production is defective, so infections can occur. One of the leading causes of death in multiple myeloma is infection. So electrophoresis would help you in identifying monoclonal gammopathies. Subsequently, you will scan the patient for autoimmunity by the help of tests like creatinine kinase, rheumatoid factor, as well as anti-nuclear antibody, which is a good screening test to identify for SLE, scleroderma, dermatomyositis, mixed connective tissue disorder. In most of them, the anti-nuclear antibody is positive. Once you've done this investigation, the subsequent one that you will do will be a urine evaluation of the patient, a urine microscope examination, and a culture. There is no point of getting a culture being done again and again. He says you just need to do one good culture in a patient. It should be a midstream sample in the patient. The blood culture that is to be done should be 3 times. There is no need to repeat more than 3 times. The diagnostic yield does not increase by repeating the culture again and again. Why you're doing a urine and a blood culture is obviously to pick up any bacterial infection which could be picked up, and lots of time these cultures might turn out to be negative because person has already taken antibiotics. Then you will do imaging in the patient in the form of a chest x-ray, which could pick up possibility of miliary tuberculosis. Ultrasound that could help you pick up any kind of abscess. It could be a liver abscess, it could be amoebic liver abscess, pyogenic liver abscess, sometimes even a hydrated cyst could be picked up with the help of a ultrasound. And because we are talking about Indian patients, so tuberculin skin test or Mantoux, or in Western population, they might use a IGRA, that is interferon G gamma release assay. So interferon gamma release assay, IGRA, or tuberculin test or tuberculin skin test or Mantoux test are the basic minimum tests which are to be done. So obligatory investigations should be done in the patient. I'll just make you practice this again. 4 points for diagnosis of fever of unknown origin are: there should be demonstration of fever which is more than 101 degree Fahrenheit 2 times for more than 3 weeks. There should be no immunocompromised state, and obligatory investigations should be done. You see, earlier when I was a student at your age, I used to study that if somebody is having fever persistent for even duration of more than 1 week, and person was hospitalized, and we have done all the workup in the patient, and still fever is not made or a diagnosis not made, we call it fever of unknown origin. It is a very non-specific statement because every doctor will do tests from his own perspective. What they have now done is standardized the obligatory investigations to be done in a patient. He has specified that only when all these investigations are turning out to be negative, there's no immunocompromised state and the duration of fever etc. satisfied, that is when you will say that okay, the patient is having a fever of unknown origin. What I say next is again important. If they ask you what is the important cause of pyrexia of unknown origin, for India it is tuberculosis, on global basis is non-infectious inflammatory disorders, and if they write infection as well as non-infectious inflammatory causes, then infections are more than that of inflammation. Why that I'm saying so is because when it comes to developing countries, the cases that are reported of PUR are more in developing countries as compared to developed countries. So when you take up the entire data, the infections are obviously going to overrule over that of inflammation. So I highlight my statement once again. You see, the population who is diagnosed with PUO is more going to be in developing countries as compared to developed countries. So if you read the Western data, they'll just talk about NIID, that is non-infectious inflammatory disorder. And in India, it is infection. Southeast Asia, it is infection. Overall also is infection more than inflammation. When it comes to pyrexia of unknown origin, most of the time, the cause that will be found out in the person subsequently will be a atypical presentation of an infection. If it was a standard presentation of an infection, it would have been easy. It is most of the time a atypical presentation of any infection rather than some rare disease. What I mean by rare disease is, like, you will read about these terminologies, the full forms of which I will explain to you. Like when you will read regarding fever of unknown origin, you will read about these fancy terms like Sapho syndrome, or you will read about Papa syndrome, or you will read about Schindler syndrome. If you're noting it down, do keep a line blank after this, because I will use this information, or I will use this opportunity to mention regarding the manifestations of these diseases. But at the moment, I want to say that don't consider rare diseases right away. Most of the time, it is a atypical presentation of an infectious disease. Now, assuming the fact that doctor has done all the obligatory investigations that I've explained to you and still the diagnosis is not made, what you should do next is exclude any possibility of thermometer manipulation. Once this has been done, and we know that the patient is not doing this for any secondary gain, like you have asked the nurse to record the temperature whenever he comes to you, in the physical presence of nurse the temperature is being found to be elevated. In those circumstances, the next step to be done is to stop all medications of the patient, including any over-the-counter drugs in the patient. Once you stop all the medications of the patient, if the fever persists even after 72 hours of stopping the medication, then it is unlikely to be due to the medication. The list of medications I will discuss with you subsequently, but at the moment I'm saying any kind of medication, even over the health tonics or Ayurveda or homeopathic medicines which are available, all should be stopped in a person, because after all foreign products which are ingested in the body can manifest in the form of presence of fever. Assuming the fact that obligatory investigations are negative, thermometer manipulation is not there, all medicines have been stopped, 72 hours have passed by, 96 hours have passed by, 1 week has passed by, still fever. Then what are you going to do next for the patient is do a fundus examination. Why a fundus examination? Because he could be having infective endocarditis of the subacute variety, and the rot spots could be presentation in a patient. So fundus will let you know about any kind of infective processes or embolic phenomenon that are occurring from the heart of the patient. Along with this, you should check for cryoglobulins, that is cold antibodies, which could be a relatively rare cause of development of fever of unknown origin or auto-inflammatory states. Assuming the fact that fundus is also normal, cryoglobulins are also normal, I'll just go back. I said all the obligatory investigations of the previous slide are negative. I have ensured no thermometer manipulation. I've stopped all medications. Fundus is negative. Cryoglobulin profile is turning out to be negative. Then I will do an important investigation by the name of FDG PET-CT. This has revolutionized the way we look at fever of unknown origin, because the diagnostic yield of this is so great that nowadays we don't need to straight away go for bone marrow aspiration or bone marrow biopsy like we used to do earlier. But if you're having an increased uptake of glucose in the bone marrow, then there could be inflammatory disease in the bone marrow, there could be a cancer developing in the bone marrow. So for lymphoreticular malignancies to be identified, FDG PET will give you an answer. Any occult cancer in the body, FDG PET will give you an answer. Even if it is vasculitis, large blood vessel vasculitis, FDG PET will give you an answer. So FDG PET cannot differentiate between infection or inflammation, but increased uptake which is occurring in specific areas of the body could pick up one infection, it could pick up inflammation, it could pick up lymphoreticular malignancies in a patient. So FDG PET is one of the important investigations that is done nowadays. And in the older version of Harrison, he was mainly focusing on scintigraphy, but now he says that the diagnostic yield of FDG PET-CT to tell you what is the cause of fever of unknown origin in the absence of any potentially diagnostic clues is much more as compared to other investigations. For the scintigraphy component, I want you to remember one, gallium-67. Gallium-67 is also taught in sarcoidosis literature. The second one is indium-111, indium-111. For another could be technetium-99 labeled RBCs. So scintigraphy nowadays, the diagnostic yield is lesser as compared to FDG PET. Assuming that you have done everything here, let's go in recap. I said obligatory investigations negative. There is no thermometer manipulation, no medications being taken more than 72 hours have passed by, fundus, cryoglobulin, FDG PET, everything is normal. Patient is frustrated, sir, what is the cause? Then the protocol says go in for a chest CT. Go in for abdominal CT, though the amount of radiation exposure will be substantial now, because you will be doing a CT, chest and abdominal CT together. Normally we never do that, no, we are very specific, but now I want to look for any lymph nodes that could be developing and could have been missed earlier. You see, in the protocol, first impression of ours is that we should first do a CT. If CT is negative, we should do a FDG PET, but in the protocol it is rather opposite. He says first do a FDG PET, because the diagnostic yield of that is higher. So though it is expensive, you see, though it is expensive, he says first do a FDG PET. If it is negative, then go in for a CT chest or abdominal CT in a person, and you might be able to pick up some lymph nodes in some nook and crannies. It could be a malignant lymphoma in a person. Assuming that even this is not turning out to be positive, then a rare cause, especially in geriatric population, to be remembered is temporal arteritis, and for that we will have to do a temporal artery biopsy in the patient. I have basically tried to explain to you in these two slides the investigations which are mentioned in the flow chart for diagnosis of fever of unknown origin. I will show you the flow chart subsequently, but at this moment I just want to get the orientation right. First is obligatory investigations. If there are potentially diagnostic clues, which I'll explain, like, there could be what are the potential diagnostic clues, PDCs? Potential diagnostic clues could be like the person who's having fever, he is also having simultaneously headache, or you could in general physical examination or subsequent neurological evaluation. General physical, you can notice that is GCS is on the lower side, or in the neurological examination, you notice that he had some kind of neurological deficit. Then we could perform a lumbar puncture in the patient. So potential diagnostic clues in a patient could be in the form of fever associated with headache. CSF could be then done to identify for causes like tubercular meningitis, cryptococcal meningitis, which are relatively rare causes and could present as fever of unknown origin. There could also be a aseptic meningitis, which is called as mollaret meningitis. This is, however, only to be done if there is a potential diagnostic clue, like I said, headache present. Or another potential diagnostic clue I can mention is patient is having cytopenias, and you are noticing that the size of the liver and the spleen is gradually increasing in the patient, or the lymph node size is increasing in the patient. That indicates that I am ready for a bone marrow aspiration / a bone marrow biopsy, and even a bone marrow culture in the patient, because there could be some infections that could be causing a development of hepatosplenum again. In fact, if there is any evidence of tuberculosis present in an individual, whether from chest X-ray or from Mantoux test, if there is any feature suggestive of TB, like it could be development of a gradually enlarging matted lymph nodes in the neck of the patient or anywhere else, and these lymph nodes in the chest were demonstrated on the basis of a CT abdomen, then if tuberculosis is positive of the disseminated variety, then he says the investigation for diagnosis of disseminated tuberculosis is a liver biopsy. Very surprising, but he said for disseminated TB, do a liver biopsy and a CBNAT evaluation of the liver biopsy specimen. So PDCs basically mean not a public display of any cuddling, etc. It is basically a potential diagnostic clue present in a patient. Assuming the fact that there is no potential diagnostic clue available whatsoever, then the algorithm goes like this. He says obligatory investigations negative, then go in for fundus and cryoglobulins, negative, FDG PET whole body, negative, chest CT, abdominal CT, negative, a temporal artery biopsy in the patient. So if you get this basic data right, you would be in a better position to understand the algorithm. And I'll just move my slide to show you the algorithm that I have described here from Harrison, so that you are now going to have a better orientation. If you look at the upper part of the slide, he has said that if you suspect fever of unknown origin in any person, stop all medications whatsoever, antibiotics, glucocorticoids, because if antibiotics will continue, then the cultures will turn negative. Glucocorticoids can shrink lymph node of any etiology. Glucocorticoids can shrink lymph nodes of even tuberculosis. So you might miss out a diagnosis of tuberculosis, and in fact steroids will decrease immunity. TB can spread, get it converted into disseminated TB. So he says, do obligatory investigations in the patient, which I've explained to you in the previous slide. Exclude manipulation with the thermometer. Stop all kind of medication in a person. Check for potential diagnostic clues. If potential diagnostic clues are absent, the investigation to be done is cryoglobulin and fundoscopy. This is what I taught you. Fundoscopy for evaluating endocarditis manifestations, cryoglobulin for autoinflammatory states. If not giving any evaluation, go in for FDG PET CT. If scintigraphy is also normal, if FDG PET picks up the diagnosis, great, the end of the flow chart. But if you are finding in a person, FDG PET is abnormal would be like there's an increased uptake in the bone marrow, then go in for a bone marrow biopsy, go in for a culture. But he says that you've done everything possible for your patient, but in spite of that, there is, I would say, the end of the road. Then in the end of the road, he says that the investigations to be taken into consideration are a chest and abdominal CT and a temporal artery biopsy in a patient. So these investigations are the ones which are the main points of the entire flow chart that I want you to understand. And if you get the names right for these, because most of the time the questions set to you would be regarding the initial investigations to be done, the subsequent investigations to be done, and he can say either ask you the sequence, or he can say all except for which investigations would or would not be done for the patient. So you need to get the orientation right for these. Coming back in our slide, I had mentioned regarding some of the rare terminologies before you, like I had mentioned SAPHO syndrome, Papa syndrome, Schnitzler syndrome. These are relatively rare causes, because the causes for fever of unknown origin could be numbering going up to about 200 causes. So when it comes to SAPHO syndrome, they have asked the full form of it, so we'll just practice it, though I think you know it from Orthopedics, S would stand for synovitis, A would be standing for acne, then would be pustulosis. I cannot write as fast as I can speak, so I'll be a little slow here. Then is hyperostosis. And you need to practice this, please. So it's not that I'm just trying to make it difficult for you. They have asked the full form. And then is osteomyelitis. You go through the orthopedics MCQs of AIMS exam and even central exams. They've talked about SAPHO. So synovitis, acne, pustulosis, hyperostosis, and osteomyelitis. For Papa syndrome, PA would stand for person having a pyogenic sterile arthritis. Very surprising term. PA, that is a pyogenic sterile arthritis. The next PA stands for presence of pyoderma gangrenosum. You read about pyoderma gangrenosum as a lesion on the shin of a person of ulcerative colitis and Crohn's disease. The same pyoderma gangrenosum that you read in inflammatory bowel disease is being discussed at the moment in association with acne. So Papa is pyogenic sterile arthritis with pyoderma gangrenosum and acne. And then is Schindler's syndrome. This is a triad. The three things in the patient are urticaria, presence of bone pain, and presence of monoclonal gammopathy. So very surprising terminologies, but do remember this relatively rare information as well. I'll repeat my statement once again. When it comes to fever of unknown origin, majority of cases are those of common infections with the atypical presentation. Common infection with atypical presentation as compared to the rare diseases. So they are only to be considered in the pecking order only when the common infections have been ruled out. And as I said, overall global basis, infection is more common a cause than non-infectious inflammatory causes. So I will now describe for you the common infections which are responsible for development of infective endocarditis. The first one on the agenda is obviously TB of the disseminated variety or extrapulmonary variety. After that is endocarditis. The endocarditis I'm talking about is not with standard organisms but with those which are difficult to culture. So lots of times the report will come as culture negative endocarditis, that is with HACE group of organisms. I will give you the full form of HACE group of organisms, but before that I'll finish the list of bacteria which are difficult to culture and are responsible for endocarditis. The vegetations here might be very small in size, and you know the fact that if the size of vegetations is less than 2 mm, then echocardiography will turn out to be blind to it and blood culture will also be sterile. HACE, Q fever, Bartonella are bacterial causes which can be difficult to pick up. Then could be sterile endocarditis, which is called as meranteric endocarditis. This meranteric endocarditis is associated with vegetations on the lines of closure, and I've discussed regarding meranteric endocarditis in the infective endocarditis lecture. It can be associated with adenocarcinomas. Then could be SLE, that is Libman-Sachs endocarditis, or it could be associated with antiphospholipid antibody syndrome. So we could have both infective and sterile endocarditis as responsible for fever of unknown origin. Alphabet H would stand for Haemophilus aprophilus, not Haemophilus influenzae, but I repeat the statement again, aprophilus. A does not stand for Acinetobacter but stands for Aggregatibacter. Alphabet C would stand for Cardiobacterium hominis. Alphabet E would stand for Echinella. And alphabet K would stand for Kingella. These are relatively tongue-twisting names, but it is a worth effort to remember regarding the endocarditis quantum component that could contribute to fever of unknown origin. Then there could be GI cause in the form of diverticulitis. Diverticulitis will always develop in a setting of pre-existing diverticulosis, and culosis usually occurs in people who are having a long-standing constipation. Cause number 4 to be remembered is vertebral osteomyelitis. All of these causes which are having a itis in the end can be picked up by a FDG PET. The remaining 3 important infections which are to be remembered are Q fever, that is query fever caused by Coxiella burnetii. Then is Whipple's disease, for which serology has to be done, that is for Trophairma whippleyi. Whipple's disease is also cause of malabsorption syndrome in a patient. And lastly, you might have to take history regarding travel by the patient to zones where some infections are common. Like for example, he might have come to India where malaria and Kala-Azar is common. Or this guy is a explorer, like he works with National Geographic Channel, and he went into a cave, and when he goes into a cave, then he could be inhaling bat droppings. So inhalation of bat droppings, as you are aware, can contribute to development of histoplasmosis. Or it could be desert rheumatism, that is coccidomycosis. So this is a list of common infections which might actually be responsible for fever of unknown origin, and they have to be picked up on the basis of the algorithm that I mentioned earlier. And all the conditions that are having a itis present, they all would be having FDG PET as an abnormality, including osteomyelitis. But when it comes to Whipple's disease, there would be a coexistent malabsorption syndrome present in a patient. So when it comes to Whipple's disease, there would be a what he's saying as a PDC, that is a potential diagnostic clue. For Q fever, there could be a valve lesion which could be present in a patient, and the valve lesion has got infected. So this person is keeping cattle in the house, like a child of rheumatic fever in India. They are keeping cattle in the house, and he's having a valve lesion which has now become infected. So how would I suspect it? I might get a splenomegaly. One of the examination findings of infective endocarditis is splenomegaly, or I might get rod spots. So if you're having some kind of PDCs, that is potentially diagnostic clues present, then you can think in terms of possibilities of these infections. But first, the common causes have to be ruled out, the ones with itis, which can be picked up with help of the algorithm I have mentioned. Assuming the fact that the infection component is not contributing to fever of unknown origin, then you need to consider regarding NIID, that is non-infectious inflammatory diseases. Now, non-infectious inflammatory disorders, the important ones from MCQ perspective to be remembered is large vessel vasculitis, and an important one which is common in India is Takayasu's arteritis, and one that is more common in Central Asia is called as Behçet's disease, which is also called as Silk Road disease. Hilar lymphadenopathy developing in a patient, breathlessness in a young female, that could be sarcoidosis. If it's a relatively younger patient, especially a teenager or adolescent, it could be adult onset juvenile rheumatoid arthritis, which is called as adult onset Still's disease, where a potential diagnostic clue could be uveitis present in a patient. Just to complete the list, I'll next mention another one which is important from MCQ perspective, that is polymyalgia rheumatica. So though the list is really very extensive, including rare conditions like Sappho syndrome and Schnitzler syndrome included here, but I've just mentioned the important ones that are to be considered from the exam perspective. Assuming the fact that the infection component and the NIID component has been ruled out, then what would you think in terms of is what we discuss next? And that could be in the form of evaluation or lookout for a tumor. Most of the time, the tumor that we're talking about is a malignant lymphoma, mostly a non-Hodgkin's lymphoma. In lymphomas, fever usually precedes the development of lymphadenopathy. It could even be blood cancer, because you see, in blood cancer, you are having immunocompetent cells. Those immunocompetent cells do not know how to fight an infection. So fever can be a presentation of blood cancers or with respect to that of a lymphoma. However, if the tumor part has been negated by repeated evaluation of the patient by you, including a FDG PET scan which is negative, then cause could be in the form of drugs. The important drugs to be remembered from MCQ perspective which can cause drug-induced fever is allopurinol, which is used for gout. Anti-epileptic drugs. Anti-epileptic drugs which are notorious for this are lamotrigine, phenytoin, valproate, the routine common anti-epileptic drugs. Then to be remembered is sulfur drugs that you prescribe in your OPDs in government hospital, because most of the time on government supply we have cheaper antibiotics available. A diuretic by the name of furosemide and a cardiac drug by the name of quinidine are notorious ones to cause development of drug-induced fever. And if these causes have been ruled out, then you always have to take into consideration one, what is called as factitious fever, and second is called as fraudulent fever. So what we've learned today is that in any case of pyrexia of unknown origin, thorough history taking is important, because that can give you potential diagnostic clues. You will be asking the patient regarding the pattern of fever, which is important. Duration is obviously one of the prerequisites for diagnosis, but the pattern of fever, like remittent or intermittent fever, quotidian fever, would give you some kind of insight regarding a possible infectious cause present in a person. Medical history, past medical history will also play an important role, because he might be taking some medication for the same, which could range from allopurinol to gout or furosemide for any kidney involvement, so that you can know that a medication is responsible for it. Then sexual history, sexual contact, recent sexual contact, number of partners the person has had. They can give you an idea regarding a person who could be having a promiscuous behavior and ending up with some kind of a nasty infection, which has to be identified. Travel history is important in a person in a sense that if the person has traveled on a leisure trip, like an American person going to Bihar or going to West Bengal suffering from Kala-Azar, contact with animals has to be elicited properly because it could be both a occupational exposure as well as a hobby of the person, or the person could be keeping pets, or the person went on some holiday and he came in contact with some animal and then he got infected. After proper thorough history taking, examination of the patient is also important in a sense that you will scan the eyes of the patient, a fundus examination. A thorough examination for lymph nodes in the patient should be done. In an old person, you will palpate the temporal arteries because if you can feel a nodular structure at the TM joint of the person, it could be giant cell arteritis as a cause. Organomegaly for liver and spleen would give you insight regarding a disseminated disease process. Any previous surgical scar, thorough skin examination and mucosa examination, including genital examination if required based on the sexual history of the person, is required so that you can get an idea regarding what are the potential diagnostic clues in the person. So on the basis of the explanation that I've given to you, in any case of fever of unknown origin, a thorough history taking is important. Why history taking is important is because not only do you want to know the duration of the fever, but even the pattern of the fever, because remittent or intermittent fever would give you an idea regarding a possible etiology. Medical history would mean that you will ask him whether he's taking some drugs per se. It could be allopurinol for gout, it could be anti-epileptic drugs which could be contributing to the same. Do remember, if you discontinue a drug for more than 72 hours and still the fever is persisting in a patient, it is unlikely to be due to the drug. Sexual history, number of sexual partners, promiscuous behavior will play a role. Travel history will play an important role. And most importantly, during travel, had he had contact with any animals, because person could be having hunting as a hobby, Western countries. So we need to identify establishment of contact with animal. It could be like in India, they're keeping cattle in the house, so Q fever coming up, or it could be like a person who's a hunter by profession in America, and this guy came in contact with deer or came in contact with a rabbit, and then he ended up with tularemia. So we need to keep up those possibilities in the mind. For examination perspective, you need to scan the eyes, that is fundus examination, do lymph node examination, temporal arteries for giant cell arteritis, liver, spleen of the patient because you want to pick up an organomegaly component, any previous surgical scars because there could be potential abscess formation related to any previous surgical scar, then a skin examination of the patient, and then mucous membrane examination including genital examination if warranted based on sexual history can be done to identify causes of pyrexia of unknown origin in a person. So the potential diagnostic clues that could be present in a patient, and I have explained, could range from headache in a person with some neurological sign that you picked up, so you will think in terms of a CSF study being done, or for that matter of fact, if a person is having let me say features suggestive of disseminated tuberculosis, then he says liver biopsy should be done in a patient with the CBNet, or he says that you have demonstrated subsequently a cytopenia, initially counts for normal but now cytopenia is coming up in a patient, organomegaly is gradually developing in a patient, then you will have to do a bone marrow biopsy in a patient with the culture. These investigations are specific to a particular cause, but the general investigations or the algorithm is what I've explained to you, where we will also be doing a FDG PET DOPA in a patient. Just to demonstrate the generalized protocol, I would like to state a question before you that is given in Harrison, where he is described a 72-year-old female. This lady was having low-grade fever, was also feeling tired all the time, though she was physically active prior to that. She had no coronary artery disease, she was not on medication for hypertension or coronary artery disease, and she has been suffering from this fever for almost 3 months, and regularly she has been seeing her physician, but the diagnosis was not made, and she was not on any medication whatsoever in spite of her old age, no hypertension, no coronary artery disease, so there was no drug intake in the patient. Her husband had expired a couple of years ago, so there was no travel history also. She was not having any pets at home. There were no pets at home, no contact with animals whatsoever could be established in this lady. Accidentally, she never came in contact with animal, and there was no pets in the house. So the doctor suspected she could be having giant cell arteritis, but her ESR was normal. Normally in giant cell arteritis, ESR goes up to 100, and there was no abnormality with respect to a temporal artery. Normally the temporal arteries will become thrombosed and you can feel them as a cord-like structure under your fingers. So as such, when obligatory investigations were performed on this lady, the only thing that was substantially that was found was C-reactive protein was positive, and she was having a normocytic normochromic anemia. That was the only two findings that was demonstrated on obligatory investigations. So in this lady, FDG PET CT was done, and I'll just show you the image of the FDG PET CT, which is the one that is shown here. You can see that in this lady there is uptake of radioactive glucose in the brain and in the bladder. That is understandable in the heart because all these tissues will definitely take up some amount of glucose, but you can see a very substantial amount of increased uptake in the subclavian arteries of this person, which indicates that the person is having a large vessel vasculitis. So the diagnosis of this lady on the basis of this image that he has given in the current edition of Harrison was made as Takayasu's arteritis, and the person was put on steroids, and that resulted in improvement of this particular patient. So finally, coming to the treatment of these patients, you would have seen that in India earlier we were giving empirical ATT to almost everybody in whom the fever of unknown origin diagnosis was made. But now he says that be selective. If the person is stable, then do not give empirical antitubercular treatment. Yes, if you're having CNS findings in a person, encephalopathy, altered sensorium, hemiplegia, brisk reflexes, or he says that the patient is hemodynamically unstable or person has become more sick as compared to what he was earlier, then he says okay, you can give ATT. But in stable patients, ask the patient to be patient before you can conclude, and do not give or waste your firepower by giving ATT on almost all patients. Another drug that is recommended for management in especially Still's disease, which could be picked up in children, is non-steroidal anti-inflammatory drugs. Colchicine has been recommended for management of familial Mediterranean fever, which is obviously central part of Europe. And another drug trial which is recommended is anakinra. It is a interleukin-1 receptor antagonist. You all know that interleukin-1 is the main cytokine responsible for development of fever. It resets the temperature of the hypothalamus. So anakinra is a interleukin-1 receptor antagonist, a trial of which can be given if the cause is not determined. Please appreciate the fact that if the question says what is the best treatment for fever of unknown origin, the answer is cause-specific treatment, because we need to identify what is the etiology and treat it. But if no cause is determined in the patient in spite of intensive workup, which happens in about 10% of the cases, then he says that we should be going in for these aspects that I mentioned, that is empirical ATT, NSAIDs, colchicine, and anakinra for the patient. So these are details for fever of unknown origin that I would like you to remember. So keep hammering, guys, keep studying, and I'm sure you will come out with flying colors. I know this was a relatively longer discussion because multiple infections can come in, but I would just mainly like you to remember the basic obligatory investigations and the flow chart that I have mentioned before you, especially with respect to the importance of FDG PET, then cryoglobulins and fundus, and then lastly possibility of temporal artery biopsy being done in the patient to keep a possibility of giant cell arteritis to be made as a diagnosis. Please appreciate the fact that most cases will always be having diagnostic clues, so you would be able to identify a specific infection. The right hand side is mainly for where the diagnostic clues are not there and you are in a blind. I mean, what should I do? The patient is literally hopping mad. He says, doc, I've been to you so many times and there is no diagnosis per se. That is the right side of the table is mainly for where potential diagnostic clues are not very clear in an individual. And most of the time, MCQs will mostly be on the difficult side, because if he wants to give you an infection, that would be straightforward. If he wants to give you tuberculosis, you can pick it up. If he wants to give you malaria, you can pick it up. But the PDCs are absent in a patient. That is where we will follow this algorithm, is to be remembered for this condition. So these are the details, guys. Thank you so much for your patient hearing for this one.